Good evening. My name is Dr. Ben Goldstein. I'm director of the Center for Youth Bipolar Disorder, and it's an honor to have you here with us today in person and virtually. Before we begin, I just wanted to start with a land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilization with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the colonial records office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805, with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So we're very fortunate to have Sarah Downey, our CEO and president of CAMH, who's going to be making some opening remarks. Sarah joined CAMH in 2022 as CEO, having served prior to that at Michael Garron Hospital for 7 years. She is a leader in cancer and mental health programs and service delivery, community building, and she's the recipient of the Trudeau Medal from the Ottawa Telfer School of Management. Welcome, Sarah. Thank you for joining.
Thank you, Ben, for that warm welcome, and welcome to CAMH. This is a really important day and a really important event. And I'll talk a bit about that in a second. But for those who are here in person, you're in the Errol Family Auditorium. And I worked at CAMH before I went away from CAMH and have returned. And when I stand in this podium and I think about events like this today, we built and designed this space with it right here, and you can overlook Queen and Ossington, with big windows so that people would be able to see into CAMH and to demystify mental illness and to make it more acceptable for people who live with these illnesses to be part of society. It always gives me great pleasure when we welcome members of the public in to share with us in this important mission and cause in such special places like this that were designed to do just that. So I'm honored to be here. Maybe I'll tell a very quick story about Ben Goldstein. When I was here last time, I left in 2015 and went to Michael Garron. But when I was here, we were trying really hard to recruit him to CAMH because he's such a superstar and has incredible expertise in youth bipolar disorder. And we really felt like what a great asset that would be to our organization. It's never easy because, of course, you leave an organization, but really what a breadth and depth of expertise that we were lacking he's brought to here and how important that is. For an organization like CAMH that is a comprehensive mental health center that's developing such deep expertise in mental illnesses that I know are fundamentally changing the way we see them, diagnose them, treat them, recover from them, and prevent them in the future. And so I just thought I'd say that it was, I'm so thankful for the people who knew just how to get them here. And although bipolar disorder is the fourth leading cause of disability among youth worldwide, bipolar disorder in youth remains greatly under-researched. And as such, the remarkable productivity and discoveries of our center team serves as a crucial role in advancing knowledge and optimizing treatment of youth bipolar disorder. A fundamental and distinguishing feature of the Center for Youth Bipolar Disorder is its focus on integrating mind, brain, and heart. A focus on the heart bipolar connection offers patients and families hope for a future where the causes of youth bipolar disorder are better understood. Novel treatment options are available, and stigma is diminished. Our CYBD truly exemplifies CAMH's motto and ethos of mental health is health. Earlier today, the center hosted their third annual research symposium, bringing together Canadian and international researchers, trainees, and mental health professionals to take part in presentations and discussions on current research in bipolar disorder with a special emphasis on youth bipolar disorder and the Heart Bipolar Link. Tonight's event, which you're all participating in, is a reflection of the center's mission and dedication to sharing knowledge and research about youth bipolar disorder in order to demystify and increase awareness of the condition and improve outcomes for youth that live with this illness. Again, thank you for being here. Thank you for participating this evening. Thanks to those who put it on. So important to share what we know and share with the public in such a beautiful and accepting space. So thank you and enjoy your evening.
Thank you so much, Sarah. So you heard a little bit from Sarah. I wanted to give just a little bit more context. The Center for Youth Bipolar Disorder was initially established at Sunnybrook Hospital in 2009 and moved here in September of 2020. As you heard, we're a clinical research program that emphasizes the integration, collaboration, especially on the Heart Bipolar Link. And our mission is to improve outcomes for teens with bipolar disorder through cutting-edge research, treatment, education, and importantly, advocacy. We view bipolar disorder as an illness that's highly familial, highly complex, and yet under-researched. And it's for that reason that we really do need a center focused on youth bipolar disorder. As you heard from Sarah earlier today, we had a great research symposium, and these are the keynotes that you see from the United States, colleagues talking about the future, talking about digital characterization of neuroimaging, of individualized treatment approaches. And so that was really inspiring. As you can see, this is a picture of Vincent van Gogh that is right across from the Art Gallery of Ontario. And World Bipolar Day was assigned to March 30th by virtue of that being his date of birth. I wanted to emphasize something that we're really proud of at CYBD, which is patient and family engagement, which occurs in a number of different domains. So we have a youth advisory council, and for those who came in on site, you saw the table set up with the booklet from the Youth Advisory Council, which has really had worldwide reach. I've heard from many sources, been a source of comfort, inspiration, and hope. And so for those who are not here today, it's on our website, freely available for a PDF download. For those who are here, grab a shiny covered copy because they're great. And we have an ongoing Youth Advisory Council that's focused on new projects, in particular, engagement with researchers to help disseminate research in a way that's plain language, it's accessible, and that's relevant to people. We work with partners at CAMH in terms of dissemination, including youth and parents who present in our webinars. We have an ongoing collaboration with Hope and Me, or the Mood Disorders Association of Ontario, and with CREST BD. We have consultation forums in our research where we hear back about what the experience was like, about guidance for the future, and we engage with youth in the planning phases, not just after the studies have been decided upon. And finally, on site, we have a great Wall of Hope, which is an art medium where youth that have experienced bipolar disorder write messages of hope for those that come after them. And it's definitely been my experience that it has hit the intended mark. Here's a picture of the booklet. And then our motto is, to us, heart not only represents dedication and care, but it is a symbol that bipolar disorder is linked to cardiovascular risk and affects mind, brain, and body. And hopefully that will come forth with clarity as the evening progresses. So I wanted to invite Andrew Comte to speak on behalf of the Mood Disorders Association of Ontario. Andrew has been working with us since our very first patient and family evening, more than 10 years ago. Thanks for joining us, Andrew.
Hi, everyone. So my name is Andrew Comte. I work at Hope and Me, the Mood Disorders Association of Ontario. And it's truly been a pleasure working with them all of these years. We partnered with them on many occasions, and it was kind of really important to focus on younger folks living with bipolar disorder, and also to celebrate all of the great things that they've done in terms of hope and recovery. So I was kind of trying to decide what we should call today's presentation, and I thought it was really important to call it Dare to Hope. So basically, we've been around for almost 40 years now, and we focus a lot on different types of peer support programs. And our focus is definitely our focus is to help people living with different mood disorders, along with their family members and caregivers. So in today's presentation, one of the things I'm going to be talking about is, I think had some informal chats already with some of the audience members. I'm going to talk about one of the programs that we're doing called Peer Talk, and also our Youth Living Well program, Changing Minds with Youth, Stop, Drop, and Talk. We also created a number of videos called Boost Your Mood in a number of our different youth peer support groups. So one thing I thought that was like very important is that it was kind of really important to develop a speaker series in partnership with the organization called Toastmasters International. And what we wanted to do is be able to kind of reach out to the community and sort of talk about different types of mood disorders and help to decrease the stigma around that. So we decided to name the Peer Talk program Speak Your Truth and Find Your Strength. And as a result of that, we've been able to kind of train a number of people to take the time to talk about their lived experience in sort of an empowering way and help to sort of decrease the stigma about living with things like bipolar disorder. So basically, we've now created a Peer Talk Speakers Bureau. And if you want to kind of check out our website for some of our speakers, it's called peertalk.ca. Also wanted to mention, as a provincial organization, it's kind of really important to provide a number of kind of free kind of services across the province of Ontario. And particularly, we wanted to reach out to a lot of the smaller communities as well. So a lot of our programs are virtual now because it's kind of really important to be able to kind of reach some of the smaller communities as well. But it was very important for us to provide youth-focused programming. So we've got two programs, one called Youth Living Well, and basically it's a drop-in group because a lot of younger folks are kind of very busy with their own lives. They're maybe kind of in school. So we have a drop-in program for folks 14 years to 29 years old. And we provide youth with a number of different kind of skills and very kind of practical skills in terms of how to kind of live well and live a good quality of life. And then we also, I think last year you talked about DBT, dialectical behavioral therapy, but we also have been providing DBT skills groups specifically for younger folks between the ages of 15 and 19 years old. And they're able to sort of develop different types of skills to help manage their mental health. Also wanted to mention another really great program that we're offering called Changing Minds with Youth. And what's kind of really crucial about this is we partnered with youth to actually create this really great program. So it's a chance to sort of connect, share what your experiences are, and also provide one-on-one support to one another. And it's the primary focus is just to bring people together, especially with younger folks, so that you can kind of share and work together, so that you can kind of focus on your personal wellness and different recovery strategies as well. And it was really great that it was actually designed by youth. So that website is called Changing Minds with youth.ca. And as I kind of mentioned before, we do offer a number of programs specifically for youth. And they're basically kind of drop-in groups because oftentimes, younger folks are busy with school, other different types of responsibilities as well. And again, I think the host muted me. It said, okay, I'm unmuted. And then it was actually designed and built for youth. And then it's kind of really important for us to offer sort of drop-in groups because people don't necessarily want to register for different programs. Their schedules may be really busy. So it was kind of really important for us to offer different types of drop-in groups for youth ages 14 to 29 as well. One thing I kind of want to mention is, there's so many different types of videos and things kind of out there. You don't really know what's kind of good to watch. There's so much kind of misinformation out there. And, the first time a younger person told me about TikTok, I was thinking, are you talking about TikTok? Like, what are you talking about, TikTok? And then when I first started looking at it, I can't stop like scrolling through all of these different videos. So we worked with a number of youth to design very kind of short kind of videos. So you can kind of reach out to different audiences about different mental health topics. So I'm just going to share a short little about 2-minute video. And this one is one from one of our youth volunteers. And it's called part of the Boost Your Mood webinar series. And this one's focusing on stigma and self-stigma. Because stigma, especially around mental health, is something that's definitely not talked about enough. And having that stigma within the community and others, but also that self-stigma can be really difficult when you're trying to reach out for support. So it's really important for us to sort of open up that discussion so people realize all of the really great supports and resources that are out there. So I'm gonna share this quick little video.
This segment is about stigma and self-stigma. Mental health awareness has increased throughout the year, but it continues to be met with widespread stigma in hospitals, workplaces, schools, and in many communities. Perhaps one of the most significant challenges about stigma is that mental illness is largely invisible. Stigma is often perpetuated by the media, which can create misconceptions about mental health and mental illness, and this leads to individuals believing these negative views about their own mental health or mental illness. There are 2 types of stigmas: self-stigma, which are thoughts and feelings you have for yourself, so feeling shame for having a mental illness, and social stigma, which are thoughts and feelings you have for others, so believing your mental illness is a burden to others. Self-stigma is having internalized shame and acceptance of stereotypes and judgmental beliefs about one's mental illness. Self-stigma is learned, but it can be unlearned once you start building self-compassion. Stigma has a few impacts in an individual's life. It creates shame and uncertainty that impedes what could be a clear path to recovery. Stigma can lead to social isolation and a lack of support that leads to feelings of loneliness and helplessness. It perpetuates experiences of discrimination, and it can prevent vulnerable people to seek help, or they become unaware of the resources to seek for support. There are a few ways to reduce self-stigma as a friend, a family member, or a support worker. You build strong and non-judgmental relationships. You are a supportive presence. Utilize non-discriminatory language. You reinforce and celebrate successes, even if they're small, and you help them gain a sense of control through their self-determination.
So basically, these are kind of short little like 2-minute kind of videos talking about kind of different topics. And we got lots of really great, younger folks. We have like so many young folks as that are kind of volunteers with us. We actually have a very small number of staff, but we could not do all of our work with all of our great volunteers, and a lot of them are younger folks. And they kind of help to kind of design all of these different types of resources. So I'd kind of mentioned about Boost Your Mood webinars. And this great person talked about kind of a stigma that's out there around mood disorders and mental health, but also specifically about self-stigma. You know, a lot of people, you know, are that are, especially with younger folks these days. I remember, you know, way back in the day, if you kind of got bullied, you were kind of just bullied within your own kind of school. But now with like social media and stuff, people are putting stuff all out there. And maybe one of the last things that you want to do is kind of talk about your own mental health challenges. But it's kind of important to kind of open up that kind of discussion. So that's why we want to make these short little kind of videos and talk about the topic about stigma that's kind of, you know, happening everywhere, but also that self-stigma, because you might not necessarily, like, you're kind of, you know that something's maybe not, something's going on with yourself, but you don't really necessarily want to go to a doctor or talk to a family member about that. If you kind of sprained your leg, it'd be easy. If you had the flu, it'd be easy to pick up the phone and book an appointment with your family doctor. But if you're struggling maybe with your mental health, there's so much kind of stigma around that. So it's kind of really important for us to open up that discussion, especially with younger folks, by creating different topics and keep them like kind of very fairly short, and all kind of designed with a lot of our youth volunteers. I just want to mention, I think we had a chat with another person before I started the presentation, but we offer a number of really kind of great different types of peer support groups. But I kind of want to mention we offer a number of youth and young adult peer support groups. They happen in the evenings. So our office is actually open from 9 to 9, from Monday to Thursdays, and then 9 to 5. And a lot of our appointments are, a lot of our programs are virtual. So you don't necessarily need to take the transit or deal with all the construction at Yonge and Eglinton where our office is. So it's much more kind of accessible. These support groups are open from every Wednesday from 7 p.m. to 8:50 p.m. So we have trained young peer support facilitators as well. And we have lots of people kind of joining these peer support groups as well. I also want to just kind of quickly mention, we offer so many really great kind of services. We have what's called a warm line. So basically, you know, if someone's having kind of, you know, a bad day, and you kind of want, our motto at work is talk to someone who's been there, because every single staff member, board member, volunteer has either lived with a mood disorder or has been a caregiver or a family member of a mood disorder. So it was kind of really important for us to provide what's called a warm line. So if someone, you know, doesn't really kind of want to talk to their family members about what's kind of going on, or their family doctor, they can pick up the phone and call our warm line and talk to one of our great staff or volunteer members and talk about what's kind of going on. And that line is open from 9 to 9, Monday to Thursdays, and 9 to 5 on Fridays as well. And then if you want to find out about any of our free programs, they can help you register for those as well. So as I'd mentioned before, we offer lots of different virtual peer support groups for all sorts of folks. So definitely for younger folks, the LGBTQ community, racialized communities as well, for women, for men, people living with bipolar disorder, people living with anxiety as well. So all sorts of different types of peer support groups. One other thing that I kind of mentioned to one person is, if you're first kind of going to a peer support group in a group setting, you may not necessarily want to kind of open up. So it's kind of really important for us to offer one-on-one peer support. So you can just chat one-on-one with a person, and then we also offer short-term counseling. So I know sometimes, depending on where you're living, it could be really difficult to find a registered psychotherapist, but we offer free short-term counseling as well. And then we offer a number of different recovery focused webinar series on our website as well. So I'm getting towards the end, but I wanted to leave this one little quote from Dr. Salk. And it's kind of very much in line with the theme of what we're going to be talking about today. And it's just kind of important to note that there is hope in dreams, imagination, and the courage of those who wish to make these dreams a reality. So I thought I'd just end the presentation with that little quote. So thank you very much, everyone. And I always like to do heart bipolar disorder at the end of these presentations. Thanks so much, Ben.
Thank you so much, Andrew. And it's just been a great collaboration and partnership over the past 10 plus years. And I'm glad that it's not just annually that we see each other now and collaborate through the year. We're now to, I think, from my perspective, the most exciting and inspiring part of the evening, which is we are going to hear from a young woman with lived experience of bipolar disorder who's been working with our CYBD team. And she is, I have assured her that when she looks up in the audience, she's going to see supportive, smiling faces. So please prove me right. And with that said, Emily, please come up and join us. And we look forward to hearing your comments.
Hello, my name is Emily Lewis, and I'm a 19-year-old woman from Toronto, Ontario. Before I get to speaking about the heavy stuff, let me share some insight with you about who I am and why I'm speaking to you today. I'm a creative. I enjoy making art in my free time. My favorite way of expressing myself is a sketchbook and a number 2 pencil that has been freshly sharpened. My favorite way to spend the day is to go out only to put on a cute outfit and grab a nice coffee and maybe go shopping. I love seeing my friends any chance I get. Learning about psychology and mental health are 2 things that I'm quite enthusiastic about. So my love for psychology brought me to York University, where I'm presently a second-year student. When I was younger, one of my greatest aspirations was to study psychology. Now here I am. Let me get into why I'm here and tell you about my personal experience with bipolar disorder. When I started to notice symptoms of bipolar disorder, it was around the age of 12. This meant that my waves of depression were suicide watch, and my highs and mania meant that it was hard to get me to live in reality. Struggling through each episode, I felt as though I was screaming for help, and all I was told was that I was a teenage girl. That continued up until I was 17. From the ages of 12 to 17, I struggled with self-image, self-esteem, relationship issues, family drama, and school, just like any other teenager would, although my experience was a bit different. As a child, I grew up in a not-so-always stable environment. Challenges related to my mother's addiction would consume most days, and her mental health was the start of my own mental health journey. She signed us up for family therapy specifically for her addiction when I was 9. This was life-altering. Although I thought my therapist at the time could be my fairy godmother and grant my wishes of saving my mom, unfortunately, that was just not the case. On the brighter side, though, she saved me and gave me a life worth living goal. My therapist, who I work with from the ages of 9 to 15, gave me such a strong sense of purpose in life, knowing that I could one day accomplish the same for someone else as she had done for me. This is what kept me going through every manic episode. My first manic episode at 12 felt like a mirror shattered, and I had propelled into another dimension. I was no longer capable of having any regulation because all of my structures that I had once relied on started to crumble. The relationship with my parents broke off, and my dad started seeing someone new not too long after. The mess of it all left me lost and confused at such a pivotal age in my life. I no longer knew anything, and everything I had thought to be true felt like a lie. I lived within a daze for almost that whole year. The most vivid memory of being 12 was trying to take my life for the first time. I would seek help all the time, and I constantly knew my mood swings weren't normal. When I became mad, I became enraged, breaking anything in sight, screaming, crying. When I was sad, my whole life was at stake, and God forbid I was happy, because that only meant euphoria. I begged for a diagnosis, but everyone around me thought it was me begging for attention. In all reality, all I was asking for was a little bit of help. I did not receive any medical attention from my mental health aside from regular therapy until I was 15. It took so many episodes for me to receive help. Do you know how frustrating that is, knowing you need help, but you just can't receive it? So fast forward, I'm now 15, sitting in the doctor's office because I can no longer bear another depressive episode where I'm screaming and crying, questioning whether I should be alive or not. I could no longer bear the paranoia my mania brought every new episode. I constantly felt like everyone was after me, even people that weren't really there. I promise you, at this time in my life, I explained to everyone that my brain was split into two, left being the good, right being the bad, and I could constantly hear fighting from both sides. And each emotion had its own voice, so whenever a new feeling would arise, another voice would follow. That's what mania feels like for me. And having no skills to regulate myself or medication, I felt completely imprisoned by my own body and my mind. When I was first diagnosed, the doctors told me I suffered from major anxiety and depression. There was no discussion at the time about whether or not I could be bipolar, so they put me on a Zoloft. I was on Zoloft for around 5 to 6 months. I started taking them around 25 milligrams, but in the end, I ended up taking 150, which I personally thought was a fast decision to make and a little bit of an irrational one. I felt as though I abused the medication because I was trying to achieve a sense of normal. I severely lacked the skills to help myself efficiently during my episodes, which would lead me to self-destructive behaviors that affected every aspect of my life. I became a zombie from purposefully hiring my dose in hopes to stop the war in my head. My life had once again not felt real. It was like I was on autopilot watching my life pass by. I had once again felt so trapped. I questioned the help I'd gotten because I felt as though it did nothing. Unfortunately, not long after being on Zoloft, COVID had hit and the whole world went on pause. My doctor became unreachable and I became unwilling to seek help. I was unable to get a refill for my medication, so I made the executive decision to just stop taking them. Making this decision to stop taking my medication was the catalyst to one of the most severe manic episodes of my life. So, rightfully being lost and confused, I dyed my hair pink, I pierced my own ears, and I changed my whole wardrobe, trying some way to find myself. I had never felt more out of this world than I did the year 2020. I had become extremely distant from life and disassociated from it. And this state persisted for a further 2 years. When high school resumed, I was forced to face my mental health head on because it was starting to interfere with my success in school. One thing that has always kept me grounded is the thought that I, too, would become a clinical psychologist. So the fear of not doing well in school motivated me to seek help. Once again, but not until I was 17. My trust with doctors ran very thin, and I was cautious about taking any kind of medication. I went to my dad's doctor and simply explained that I'd been having manic and depressive episodes for as long as I can remember, and I needed a further diagnosis beyond the one I had previously been given. For the first time in my life, I had someone listen to me and not brush off what I was telling them about my mental health. Thankfully, because of her capacity to listen to my needs, she was able to connect me to the fantastic team that I get the pleasure of working with now at CYBD at CAMH. I was directly connected with Dr. Goldstein from the Center of Youth Bipolar, and I am so lucky to say that I get to work with him and all of his colleagues. Getting the bipolar diagnosis for me was validating. I knew my whole life I had had this disorder. The objective now had shifted from getting the diagnosis to understanding what bipolar meant for me and learning how to live with it in the safest way possible. Dr. Goldstein directed me to DBT, dialectical behavior therapy, and it altered my life trajectory for the better. It was my last year in high school. I was learning skills like dear man, soothe, and how to validate myself and others. These interpersonal skills helped me advocate my needs and express myself when I needed space from others. For example, when conflict arises, I often struggle with black and white thinking. But when I use skills like dear man, it helps me regulate myself and regulate the situation. So, for example, let me walk you through a quick dear man. D would be to describe the situation at hand and the straight facts of what's going on. E, express myself using I statements like I feel and I like. A, assert, ask for something, express my needs or assert clear boundaries. And the one letter that I have found the most beneficial to me and I love reminding myself is R, reinforcement. What's in it for the other person I'm talking to? What can they get out of the conversation? And the last part, man. It's just a reminder to stay mindful during the moment, appear confident while talking, and to negotiate. Ask for the other person's input and be willing to offer alternative solutions to the problem. Know when to agree to disagree. I was effectively using these skills, but unfortunately, my episodes were too strong to have just be using DBT skills. And even though they were making a positive impact, it just wasn't enough. The struggle was to start medication again. My mania had reached a peak where I had thought that if I took my medication, it would rob a part of me that I wouldn't be able to get back. I was terrified of the person my medication would make me, and I had no intention of turning into a zombie once more. I told Dr. Goldstein about my concerns, and he was adamant on helping me. It took weeks before I could finally admit to myself that I also needed the help with medication along with therapy. Dr. Goldstein started me on the Mochigene, and everything was going great. I started to stay on top of all of my responsibilities. My mood had leveled out, and I started to do well in school again. I was once again so happy and so excited to be on track. So I thought. A couple months passed on Lamotrigine, and I started to experience the one main side effect, rash on my neck. So that was the end. Although medication was not the solution at the time, I knew sooner or later it would be needed to control my irregular mood swings and episodes. I finished off my high school experience with the best grades I had ever brought home and 2 scholarships for post-secondary. This was all due to the help that I got from everybody here, so thank you. I had teachers my whole grade 12 year tell me how much I changed and how much they noticed the work that I was putting in. When I told one of my teachers in particular what I was doing with CAMH, he would always comment on how much lighter my mood was and how much lighter my energy seemed. This kept me motivated to keep seeking the help that I needed, and I finally felt on track. I felt so much progress had been made, but once again, I had another episode. Trying new medications after the failed attempts felt hopeless to me, so I refused to try again until I was faced with an episode I was too scared to go through alone. It was just last year, March 2023, where I started to feel symptoms of hypomania that I could not control. I went through a breakup that caused me to spiral, questioning my whole life existence. I was in a heterosexual relationship trying to maintain a reputation, all while knowing I was queer. I knew the moment I had broken up with him that I'd face my true identity. Every single avenue of my life started to crumble. My relationship had ended. I started to question my sexual identity. It was exam season just around the corner, and the expectations of me from others just kept growing. My cup had started to pour over, and before I knew it, I was drowning in suicidal ideations. I never had thought that I would ever go back to my 12-year-old self. But here I was, laying on the bathroom floor, as an 18-year-old, questioning if there was anything else to live for. Although I have always known that I have an amazing support system, I can honestly say that at CAMH and CYPD, they have given me more certainty than any other source in my life. I admitted to myself I needed to get medicated. I finally found the strength to realize that taking medication does not take away from my life. Instead, it enhances it. It takes so much weight off my chest. Slowly, Dr. Goldstein and I decided to go on Seroquel. To this day, I'm still taking it. It has been almost 2 full years now participating in DBT and 1 whole year now being medicated. I can proudly say that because of my team at CAMH, my life is headed in the right direction. I have achieved one of my greatest goals in studying psychology, and I have learned how to have a loving relationship with myself throughout my bipolar journey. Until I worked with Dr. Goldstein and his colleagues, Danielle and Jessica, no one would listen to me about what I needed. So thank you so, so much. I would not be here without all of your support. My favorite quote is, "It takes a village to raise a child." The team at CAMH has been one of the most patient and kind villages to ever lift me up, and I am beyond grateful. Bipolar robbed me years of my life up until now. So let me share a few things with you that I never thought I would have achieved due to my mental health. For starters, I actually made it out of high school. Those are some of the hardest years of my life. Getting into university and being able to study psychology. What a dream come true. I completed my first year and I'm almost done my second year with some of the best grades I've ever had. I traveled all on my own. I went to Calgary and Windsor. I took myself to my first ever concert, and I've been able to maintain the same job for 4 years. I have learned over the years how to love myself and get through every manic and depressive episode by asking for help. My hopes in the future are to travel to Europe, graduate from York University with my bachelor's degree in psychology, and after that, I'd like to get a master's in social work. I want to continue to make an impact in society any way I can to show my thanks to everyone who has helped change me. Thank you to everyone who's had a part in my growth. Lastly, I would like to acknowledge that I had never imagined speaking in front of all of you today, but here I am. I sincerely appreciate you allowing me to share my life experiences with you, and I hope that one day I may be able to fulfill the dreams of others as you did mine. I want to make sure that nobody feels overlooked and discarded the way I did before working with my team. I hope this resonates with someone who is listening, and I hope you know that you are capable of achieving your greatest dreams, and your life is most certainly worth living for. There will always be someone willing to listen to you. Please never give up on yourself, even when the fight's exhausting. Thank you.
It's a tough act to follow. Thank you so much, Emily, for your courage, for your candor, for teaching people about DBT, and for being an icon, a role model for people that are going through the rough patches that you went through, and to know that there's another side to it. So on behalf of the whole team, thank you so much. So that provides us with our foundation. Why are we here? What inspires the team? What is our purpose? And Emily, I think you just encapsulated all of that. What we're going to do next is have 3 consecutive brief presentations from early career young women sitting in the front row who are a slight bit anxious, so we'll ask for the same level of enthusiasm as Emily received. And they're going to cover a spectrum of topics that we think at least one of them will appeal to everybody. I just encourage people to check out our website where we have a compendium of prior evenings like this available by video. So we can't cover anything on any one night, but over the course of years, we do. So for the first introduction, I'm going to introduce Dr. Alicia Sultan. Come on up, Alicia, who's going to be presenting to us on the very timely and important topic of cannabis as it relates to bipolar disorder.
Thanks, Dr. Goldstein. So thanks everyone for joining us for the evening portion of our World Bipolar Day. So as Dr. Goldstein mentioned, my name is Alicia. I'm a scientific associate at the Center for Youth Bipolar Disorder. I've been working here for the past 7 years, and today I'm going to be talking about cannabis and youth bipolar disorder. So just to start off, a little bit about cannabis itself. So cannabis is made up of more than 500 different components, and the most abundant components are known as cannabinoids. So CBD is a non-psychoactive cannabinoid, meaning it is not responsible for the high sensation associated with cannabis use. However, it is the component that's said to have various medicinal properties. whereas THC is the main psychoactive component of cannabis, meaning it is responsible for the high sensation most people associate with cannabis use. And when we're talking about recreational cannabis use, particularly in young people, cannabis is typically high in THC and low in CBD. So this slide is just emphasizing a few news articles that have been published since the legalization of cannabis in Canada. And particularly, these are highlighting the effects and the risks associated with cannabis use, particularly in youth. And it's also emphasizing the lack of information we have on the effects of cannabis. And since legalization, we know it has led to a significant decrease in the perceptions of harms associated with cannabis use, as well as a significant increase in cannabis availability. So knowing this is troublesome because we know approximately 30% of youth with bipolar disorder have a co-occurring substance use disorder, and most commonly a cannabis use disorder. And we also know that youth with bipolar disorder have increased cannabis use relative to the general population, as well as a greater likelihood of progression from cannabis use to a cannabis use disorder, again, relative to the general population. So this emphasizes the importance of understanding this association in a high-risk population such as youth with bipolar disorder. So on this slide, we outline the symptom criteria required in order to receive a cannabis use disorder diagnosis. So we know that cannabis is common and not necessarily always problematic, but once you receive a medical diagnosis of a cannabis use disorder, this does occur once cannabis use is problematic. So for example, when an individual starts to use more than is planned, or when they start having problems with use, including use that is dangerous or causing problems with friends or family, or interfering with responsibilities at school, work, or home, this is when they start to enter the realm of an addiction or a cannabis use disorder. So overall, cannabis use leading to significant impairment or distress in one's daily life would result in a cannabis use disorder diagnosis. So previous research has shown us that there are many different clinical implications of cannabis use in individuals with bipolar disorder. And specifically, we see an increase in the associations of number and duration of mood episodes, increase in number of co-occurring disorders, increase in police contacts, sexual risk behaviors, and suicidality, paired with a decrease in medication adherence and overall life satisfaction. So it's important that I note that all these studies are observational cross-sectional studies, meaning we can't draw any causal conclusions from them. So in other words, all these studies were looked at one point in time. So we don't know whether cannabis is causing these clinical implications or just simply associated with. So we wanted to look specifically at the prevalence of cannabis use and cannabis use disorder in youth with bipolar disorder. And we did so in a nationally representative sample of over 9,000 youth. So in this sample, we had just under 300 youth with bipolar disorder, and we had just over 8,700 youth that were considered controls. And to be a control, you could have any diagnosis other than bipolar disorder or major depressive disorder. So directing your attention to the right side of the graph, you can see that the youth with bipolar disorder depicted in dark green had more cannabis use relative to the control youth depicted in gray. However, this was not statistically significant. But now if you look on the right or the left side of the graph, the asterisks do depict a significant difference between cannabis use disorder in the youth with bipolar disorder versus the control youth. So overall, this is telling us that there's not so much a difference in the level of use associated with cannabis use, but more so a difference in the problems related to cannabis use or the development of an addiction. So we wanted to take this a step further, and we wanted to look at the characteristics associated with both cannabis use and cannabis use disorder in youth with bipolar disorder. And specifically, we wanted to look at the characteristics that increased from no cannabis use to cannabis use disorder. So these characteristics outlined on the slide, such as female gender, depressive episode duration, treatment for depression, alcohol use disorder, and suicide attempts, these were all increased in the cannabis use disorder group and decreased in the no cannabis use group. So it is important I note that 3 out of these 5 significant characteristics were related directly to depression. So in addition to there being clinical implications of cannabis use in youth with bipolar disorder, we know that cannabis use is also related to brain function in youth with bipolar disorder. Particularly, I'm going to be talking about something called resting state functional connectivity. So resting state functional connectivity is essentially looking at parts of your brain that talk to each other in the absence of doing anything specific. So in other words, it helps us to better understand what parts of the brain are working together when you're not specifically thinking or doing something. So we had 3 different groups in this study. We had youth with bipolar disorder and cannabis use, seen in the dark green. We had youth with bipolar disorder and no cannabis use, so bipolar disorder only, seen in the light green. And then we had healthy control youth, seen in the gray. So as you can see on the graph, the youth with bipolar disorder and cannabis use had positive connectivity, meaning when one region was on, the other region was also on. So these regions are thought to be working together. Whereas both of the 2 other groups had negative connectivity, meaning when one region was on, the other region was off. So in other words, we can sort of think about this as 2 lights in a room. A positive connection is when both lights are on at the same time, whereas a negative connection is when one light is on, the other light is off. So we know that these regions are implicated in reward, emotion, as well as visual perception. So we speculate that these findings could represent a stronger association between visual perception and reward in those youth with bipolar disorder that are using cannabis. So next, we want to look at the various treatment options available for youth with bipolar disorder, specifically for cannabis use and cannabis use disorder. So for cannabis use, first, we would advise the youth to stop using cannabis, and then following up with educating them about the medical harms associated with substance use or cannabis use disorder specifically. If it did develop into a more severe cannabis use disorder, there are many well-known and well-studied psychosocial treatments for this. And 2 of the most commonly used ones are cognitive behavioral therapy and family-focused therapy. So cognitive behavioral therapy works with the individual on identifying and modifying their thoughts, beliefs, and behaviors that contribute to their cannabis use disorder. And family-focused therapy emphasizes the importance of family in developing a disorder and also in the treatment process. So this integrates the family into therapy, and they work on problem solving and communication skills. So there's much less well-known research and information out there about the pharmacological effects of or treatments for a cannabis use disorder in youth with bipolar disorder. So there's only been 1 study that has looked at lithium in youth with bipolar disorder, however, a general substance use disorder, so didn't focus specifically on cannabis use. And there's been 1 other study that looked at N-acetylcysteine in youth with a cannabis use disorder, but not specifically bipolar disorder. Both of these studies did find improvements over time in the cannabis use disorder. However, further research is definitely needed to be able to better understand the best pharmacological treatment, specifically for youth with bipolar disorder that have a cannabis use disorder. So in conclusion, we do see an increased prevalence of cannabis use and cannabis use disorder in youth with bipolar disorder. And we also see that cannabis use is associated with more negative clinical symptoms and brain differences in youth with bipolar disorder. And as I've mentioned, we also know that the risks of cannabis use extend across the spectrum of use and are not just limited to cannabis use disorder. And it is also not yet clear whether these differences reflect a cause or an effect relationship, meaning we don't quite know the direction of this association. So, for example, we don't know whether the cannabis use is leading to longer depressive episodes or whether the longer depressive episodes are leading to the cannabis use. But based on what we do know in the literature out there, we do speculate that this direction or association does go both ways. So for the future, we'd like to look at long-term repeated measure studies to be able to better understand this cause and effect relationship. And we'd also like to look at various dosing effects of cannabis, so including things such as potency, frequency, and duration. So potency, we'd like to look at different concentrations of the components within cannabis, and doing so would be able to help us better understand the effects of the different components within cannabis. And in terms of frequency and duration, we'd like to look into the effects of different amounts of cannabis, as well as the effects of using for different lengths of time. And lastly, but importantly, we'd like to look at various prevention and treatment strategies to be able to better help these youth with bipolar disorder and a cannabis use disorder. So with that, I'd like to thank our patients, our research participants and their families, as well as our funders, and as well as Dr. Goldstein and the whole team at the Center for Youth Bipolar Disorder. And I'd like to thank you all for your attention.
Fantastic job, Alicia. Thank you so much for walking us through that in such a clear way. Our next presenter is Dr. Megan Mio. And when Megan started her PhD focused on some of the topics we hear about today, I used to joke with her that she's a world leading expert on the connection between blood vessels in your eye and bipolar disorder, but that's become the truth. And it's been fun to watch her consulting with colleagues in Taiwan, Harvard University, and sharing with them the knowledge that she gained through her own PhD. So with that said, Megan, coming up and tell us about heart and bipolar disorder. Forgot to say one comment for folks that are in the audience. If you have questions, please write them down on the notes and then pass them to the aisle, and we'll have a Q&A at the end. And for those who are online, do the same, but just in the chat.
All right, thanks to Ben for the introduction. My name's Megan. I'm a postdoctoral fellow at CYBD. As Ben mentioned, I started my PhD with the group in 2018, so I've been here for about 6 years now. And it's been really exciting to continue work that I started back then and watch that grow and looking at it, not just in bipolar disorder, but in other patient populations. So as Ben mentioned, we're going to shift gears and focus on heart health. And I hope that by the end of this talk, we all leave with a better appreciation for why heart health is important, especially in bipolar disorder, and why it's related to the brain. So beyond psychiatric symptoms, we know that bipolar disorder confers an increased risk of cardiovascular risk factors, as well as higher risk for future cardiovascular disease. When I talk about cardiovascular risk factors, I'm talking about obesity, higher cholesterol, higher blood pressure, as well as lifestyle factors like poor diet or lack of exercise. And we know that these cardiovascular risk factors are related to mood. They're related to worse mood symptoms, to suicidality, just to a more severe course of illness overall. So there's a lot to be gained by focusing on these factors, especially early on in life. Again, this slide is just highlighting the extent of prematurity of cardiovascular disease and bipolar disorder. This was work done in a large population-based US sample. And if we look at the green figures, you can see the average age of diagnosis of cardiovascular disease is up to 17 years earlier in adults with bipolar disorder type 1 relative to adults in the general population. And looking at the side of the graph at the ages, that looks like being diagnosed with cardiovascular disease in your early 40s relative to your 60s. So that's a really meaningful gap. And we see similar trends in adults with other mood disorders like major depressive disorder. And what's also important to kind of drive home from this slide is that there's a misconception that this is just due to weight gain. You know, psychiatric medications can often cause weight gain, or maybe this is related to lifestyle factors or to substance use. But we know that this link goes above and beyond all those things. So even when those things are statistically accounted for, the age at diagnosis and the number of diagnoses is larger. So this has led our group to ask the question, what else is going on here and what could be explaining this link? And so one of the things that we're really interested in is the blood vessels themselves. This is a 7 Tesla magnetic resonance imaging scan or brain scan. This is one of the highest resolution brain scans being done at the moment, and it's showing the brain's blood vessels. And you can see, you know, just how covered the screen is. Your brain is essentially a bag of blood vessels. The brain is a really energetically active organ, and you can imagine if you were to have problems with these blood vessels, how it would have a trickle-down effect on brain function. A lot of work has been paid, or a lot of attention has been paid to this topic in adults, sort of medical conditions and Alzheimer's disease and stroke research and hypertension or high blood pressure research. But we don't often think about looking at these things in youth. And there's the question of, you know, when does this start? How is this related to mood? And, you know, what can this tell us about bipolar disorder? So the way that our group has approached this is to look kind of head to toe. So we are integrating both brain and body blood vessels. I think this is addressing another assumption that bipolar disorder is just a brain-based condition, which is definitely true. But we know that there are disease processes happening simultaneously throughout the body. So over the years, we've accumulated a number of measures. So starting from the head and moving down, we look at brain blood flow, we look at the function of small vessels in the brain. Moving to the eye, we've started to look at eye vessel imaging, which I'm going to be talking about in a moment. Then to the heart, we've incorporated heart or cardiac MRI to look at the function of small vessels in the heart. And then moving as far as the fingertip, looking at, how vessels are functioning in the rest of the body. And what we found is actually changes in almost all of these measures early on in the course of illness. So in youth who are average age 17, and I'm going to be highlighting some of those findings right now. So what I was focused on in my PhD thesis was actually this eye blood vessel imaging. So if you look at the photo on the right, this is a camera that we actually have at CYBD, and it's really similar to what you would see at your eye doctor. We have patients come in, they sit down. The eye imaging takes about 15 minutes, start to finish. It's done without the use of eye drops. It's really well tolerated by participants. And the reason we're interested in the eye is because it's actually a really great surrogate for what's happening in the brain. The eye is part of the central nervous system. These vessels are almost the same as the brain blood vessels. They develop similarly, they function similarly, anatomically, they're very similar. But the benefit is that we can easily and inexpensively acquire these measures. So relative to the brain scans that I was showing earlier, this is a lot more feasible. It's quick, it's easy, it's well tolerated. So this has kind of been one of our key focuses. So on the right side of the photo, this would be one of the eye photos we acquire. Everyone has a unique eye photo print. And we see changes in these retinal measures in youth with mood symptoms, as well as with diagnosed mood disorders. And we know that these vessel measurements can actually predict risk of stroke, predict risk of heart attack, independent of things like BMI or blood pressure. So we're seeing some early changes in the vessels themselves before we might see meaningful changes in blood pressure or cholesterol levels. So in my PhD thesis, I spent time looking at how these vessel measures were related to brain health. And one of the measures of brain health we were interested in was brain blood flow. In adults, we know that lower brain blood flow is common during periods of depression, specifically in frontal brain regions. So brain blood flow just in general is something that we're interested in. And what we found in the overall sample, so both in youth with bipolar disorder and in healthy controls, if you had better blood vessel health, you tended to have higher brain blood flow, which we consider good. And on this figure on the screen, all of the regions or the areas that are lit up red or yellow are regions where if you have better blood vessel health, you tended to have higher blood flow. And as you can see, these are pretty widespread, so it wasn't specific to one singular region. And we also see similar trends when we were looking at brain structure. So we've looked at these vessel measurements in relation to brain volume, to connectivity, so how different brain regions are connected. And we do see different trends in the bipolar disorder, teens with bipolar disorder versus the control group. So moving on to the heart, this was work spearheaded by a scientific associate with our group, Cody Kennedy. And he has focused some of his PhD work on cardiac imaging. On the right side of the screen, we actually have a cross-sectional heart scan. So in the center of that image, you can see a white apple-shaped organ, and that would be the heart. And what we're looking at here is the function of the vessels in the heart. So we have teens enter the MRI scanner and complete this breath hold task where they hyperventilate and then breathe normally, and they follow this routine for a given period of time. And this task causes carbon dioxide in the blood to rise. And when carbon dioxide goes up in the blood, your heart vessels dilate. And so we're trying to measure, how well those heart vessels dilate. And if you look at the figure on the bottom, this is showing the extent of that response. So we can see in the teens with bipolar disorder, their heart vessels aren't dilating as well in response to that task as the healthy control teens. And this was true when we controlled for the cardiovascular risk factors like body weight or blood pressure. And so we're seeing early evidence of impaired kind of vessel health that's independent of medication use or those traditional risk factors. In terms of clinical implications, I've divided this slide into the theme of the evening, which was truth and dare. So this was a very brief snapshot, but in general, our findings do provide evidence that microvessels are relevant to the brain and to heart health, and we see early changes in these measures in youth with bipolar disorder. And from a DARE perspective, we're thinking about kind of novel treatment approaches. And we think that integrating heart health into the monitoring and treatment of bipolar disorder offers many benefits. And it might not just be specific to bipolar disorder, but we could also extend that to other psychiatric conditions. So in terms of these novel approaches, I've divided it into 3 categories on this screen. For lifestyle interventions, these are pretty straightforward. We know that there are certain strategies that are broadly relevant. So quitting smoking, diet, and exercise. We know these things are important for everyone, but particularly in youth with bipolar disorder. And then we're going to kind of move towards what we think are the newer potential approaches. So in the center, we have optimizing traditional vascular risk factors. And we think that potentially repurposing cholesterol lowering medication or blood pressure lowering medication at an earlier age could be of benefit. And we also think that there's dual potential benefits. So the first benefit is that it could potentially improve brain health and mood in the here and now, but also long-term benefits in helping to improve cardiovascular health and prevent that long-term risk. And then in terms of the super new or super novel approaches, there are actually approaches that target vessel health directly. So there are some medications that can help cause vasodilation, help to improve blood flow to certain regions of the brain, and then medications that are anti-inflammatory or antioxidant, which you may have heard of, and those could help improve vessel health directly. Overall, we don't typically think about these things for youth, but our data is showing that, youth with bipolar disorder are a population that could really benefit from these new treatment approaches. So that's a summary of the work that we've done to date in bipolar disorder. And we've recently launched a study in collaboration with the Toronto Adolescent and Youth, or TAY cohort study. So that study is open to anyone ages 13 to 24 at CAMH. So we're essentially adding cardiovascular risk assessment and the vessel imaging to the study, opening it up to all diagnoses and seeing, is this specific to bipolar disorder, or do we see similar trends in youth with anxiety, ADHD, or depression? So I just wanted to acknowledge our patients and our research participants who have made this all possible, as well as Ben and the rest of the CYBD team. Thank you.
Thank you so much, Megan. Megan was saying earlier today how much she enjoys presenting to general audiences, and you could see, I think, today the passion and the clarity, and we appreciate that. You mentioned a number of clinical implications, and the connection with our next speaker is that, as you heard from Emily earlier, when people are extremely emotionally distressed, you can imagine what kind of a toll that takes on the body. And Megan illuminated a number of different approaches that we could take from a heart health perspective, but I would argue that one of them is to help people with their emotional control through a therapy called dialectical behavior therapy. So the next speaker is Vanessa Rajamani, and I'll just make a comment about Vanessa, which is that she is part of a cadre of 3 that's now become 4 therapists working in our group as research coordinators and social workers. And when they expressed interest in learning about DBT, I said, okay, but let's do this full on. Let's make sure that we're going the most rigorous possible training and offer our patients the best possible DBT that they don't have to compromise because it's research. I said, let's aim to be black belts, because the mentor that Vanessa is going to talk about shortly, Dr. Tina Goldstein, who's no relation but a collaborator from Pittsburgh, is really a gold standard therapist, which Vanessa has most certainly become, and many patients can attest to that. So Vanessa, please come up and tell us about DBT.
Hi, everyone. My name is Vanessa Rajamani. I'm a research coordinator and DBT study therapist at CYBD, and I've been working at CYBD for 11 years now. Today, I'll be talking to you about dialectical behavior therapy for youth with bipolar disorder. So dialectical behavior therapy, or DBT, was originally designed by Marcia Linehan for adult women with borderline personality disorder. And it's since come to be adapted for different complex populations, most notably by Dr. Alec Miller and colleagues, who adapted it for suicidal adolescents with borderline personality traits, and then by Dr. Tina Goldstein and colleagues at the University of Pittsburgh, specifically for youth with bipolar disorder. The D in DBT refers to a dialectic. A dialectic is two seemingly opposing ideas that are both true at the same time. So an example is sweet and sour. So thinking of the Sour Patch Candy, it's sweet and sour at the same time. Someone might experience mania and depression within the same episode. And someone might feel happy and sad at an important life event, for example, at graduation. So in DBT, the fundamental dialectic that we think about is the dialectic between acceptance and change. What that means is the patient is working on accepting themselves just as they are, and at the same time pushing for change. And the same is true for the therapist. They're accepting the patient just as they are, while also pushing for change. So this therapy really advocates for a dialectical lifestyle: balanced emotions, balanced thoughts, balanced behaviors. So when we think of standard DBT as it was originally designed, that includes weekly individual therapy, weekly skills group training, 24-hour phone coaching, and weekly DBT consultation team. So when Dr. Tina Goldstein modified this for youth bipolar disorder, she made a few adaptations. The first was the addition of a psychoeducation module, so teaching the youth and their family about bipolar disorder, talking about symptoms of bipolar disorder, talking about risk and protective factors, for example, and then also talking a lot about what dialectics are and encouraging dialectical thinking. Next, she tailored the skills specifically for bipolar disorder mood states. So there's an emotion regulation skill that's about increasing positive emotions through planning pleasant activities into your day. For someone who's experiencing mania or hypomania, that would exacerbate those difficulties. And so we wouldn't be encouraging them to use that skill. And then on the flip side, for somebody who's experiencing depression, they would absolutely benefit from using that skill. So another adaptation is delivering the skills directly with the individual family unit, so the youth and any participating parents, as opposed to multi-family skills group that we see in Alec Miller's model. And then lastly, we are alternating between individual and skills sessions week to week. So we do maintain phone coaching. It's not 24-hour phone coaching, and we do have it in the model, and we have weekly consultation team as well. So the risk for completed suicide in bipolar disorder is among the highest of all psychiatric disorders. Suicide risk increases dramatically during adolescence, and early illness onset is a potent risk factor for suicidal behavior in individuals with bipolar disorder. Up to 50% of youth with bipolar disorder attempt suicide, and at the time of intake at CYBD, 21% of youth reported having had a previous suicide attempt, 62% had suicidal ideation, and 38% had engaged in non-suicidal self-injurious behavior. DBT is an emotions-focused therapy, meaning that we primarily focus on how emotions influence behaviors. Difficulty in regulating emotion may be associated with specific problem behaviors in youth bipolar disorder. So thinking of suicidal and non-suicidal self-injurious behavior, substance use, and impulsivity. So DBT is really well matched for this population because it's specifically focusing on those behaviors and has a core focus on emotion regulation. The overarching goal in DBT is to help patients build a life worth living. So when someone first starts in DBT, they'll meet with their therapist to identify what their life worth living looks like. Who do they want to be? What do they want to be doing? Essentially, if life was worth living, what would that look like? We then directly target the problem behaviors that are getting in the way of that life worth living. So again, thinking of some examples, suicidal behaviors, non-suicidal self-injurious behaviors, impulsivity. Our goal then becomes to replace these problem behaviors with more skillful ways of being. So DBT is also a skills-based approach to psychotherapy, and those skills are arranged into the 6 buckets that you see here on the slide. So we have the core mindfulness skills, which influence all of the other skills. We have the psychoeducation module, which I spoke about. And then we also have distress tolerance, emotion regulation, interpersonal effectiveness skills, and the walking the middle path module. So all these skills are really important because they're helping that individual move towards the life that they want most. So here's Dr. Tina Goldstein, who modified DBT for youth with bipolar disorder. So she recruited youth with bipolar disorder, aged 12 to 18 years old, and randomized them to either receive DBT or standard of care psychotherapy. 47 youth received DBT, 53 youth received standard of care psychotherapy. And that standard of care psychotherapy was delivered by clinicians who had a lot of experience working with youth with bipolar disorder. They just did not have DBT training. All these youth also received medication management as part of the study. And what she found was that DBT demonstrated efficacy at decreasing suicide attempts in those that received DBT when compared with standard of care psychotherapy. And that was particularly among those who had a history of a lifetime suicide attempt. That decreased risk of suicide attempt in the DBT group was mediated by an improvement in emotion regulation, particularly among those who had high baseline emotion dysregulation. So therefore, we're seeing that DBT does have superior benefits in terms of reducing the rate of suicide attempts, and it appears that those benefits are based on an improvement in emotion regulation. So that brings us to our Ditto study, which was a collaboration with Tina and colleagues at the University of Pittsburgh to disseminate and implement DBT to frontline clinicians. So Tina and her group wanted to see if they could take that model of DBT that they had developed and then train other clinicians to adherently deliver DBT while simultaneously improving patient outcomes. So at the time, there were 3 of us social workers on the team. And so all 3 of us received intensive training from Tina and Nina, who you can see here in the photo, on DBT. And then we implemented DBT to 21 youth with bipolar disorder in our clinic. A really exciting outcome of this study was that the 3 of us therapists successfully passed the DBT Linehan Board of Certification process. And currently, there's only 29 certified clinicians in Canada. So looking at some of the preliminary results from this study. So the first graph on the left, looking at suicidal ideation, the suicidal ideation questionnaire, which looked at suicidal ideation in the past month. So the scores decreased over the treatment period. A score of 30 indicates no suicidal ideation, and a score of 41 indicates moderate suicidal ideation. And then in the second graph, that's looking at the difficulties in emotion regulation scale, which looked at emotion regulation difficulties in the past 3 months. You can see that scores on that also decreased over the treatment period. So moving towards expanding our scope, we took that training model that we received from Tina and colleagues, and we then used that model to train an additional therapist on our team. And that therapist is now also working in our studies and providing DBT in our clinic. We've also expanded to not only include youth with bipolar disorder, we also include youth at high familial risk for bipolar disorder. And then we have a couple of different of our own modifications to DBT, which I will share with you now. So we currently have 3 DBT studies running at CYBD. The first one, DB1, is that standard full year DBT for youth with bipolar disorder that we've been talking about so far. The second one, DB3, was born out of conversations about dosing. So while it's clear that many youth that we see in the clinic absolutely do require that full year's standard DBT for youth with bipolar disorder treatment, there were also some youth that maybe didn't necessarily need that intensity of treatment or didn't want that intensity of treatment. And so we want to see if youth can still get better at a lower dose. So for example, in a skills-only treatment. And so within this study, if things change throughout the course of the study, if a youth experiences an increase in suicidality, for example, there is the option to move to a different level of treatment. So for example, moving into that 1 year's standard DBT treatment. And then the last study is DB2, which is a continuation study available to any youth that's already completed 1 full year of DBT in either of the 2 previous studies. And so within that study, the youth is able to choose whether or not they want to participate in individual sessions, skill sessions, a bit of both. And they are free to choose the frequency at which they attend the sessions. And so we're able to then follow them for an additional 2 years after they've completed that first 1 year of treatment. So in conclusion, prior research shows us that DBT is superior to standard of care psychotherapy in reducing suicidality in youth with bipolar disorder due to improvements in emotion regulation. We also see that DBT can be successfully disseminated to frontline clinicians. So we hope to expand on the research identifying the characteristics that are associated with the response to DBT, as this would provide knowledge to help maximize and accelerate the benefits of DBT. And lastly, further understanding is warranted in terms of the continuation of DBT after a full year of treatment, as is research on lower dose options of DBT for a broader spectrum of youth. So we'd like to thank Dr. Tina Goldstein and her colleagues at the University of Pittsburgh, and also the generous support of the Cooper Family Foundation. Thank you.
Thanks, Vanessa. I hope that was as satisfying to deliver as it was to hear. What a clear and educational presentation you gave us. Thank you. So we're at the last stretch of the evening in terms of formal presentations. I'm going to give an overview, and then after that, we'll call the other speakers up and receive questions from the audience based on what's been written on the cards and in the chat. So as you heard, I think it was Megan that mentioned it. We challenge our speakers to have their truth, say things as they exist right now, and then their dare, which is what can be better in the future. And I'm going to do the same. So my presentation is titled Facts, Fiction, and Future Considerations in Youth Bipolar Disorder. I have no commercial interest to disclose. So we're going to go through a series of fact or fiction statements. So the first statement is youth bipolar disorder is a recent phenomenon. So I won't make people put their hand up or shout it out, but just think to yourself whether you think that's true or not. It may seem like an unusual question to this audience, but I have to tell you that despite all the progress that's been made, we heard earlier from Professor Youngstrom about the thousands of publications that have been written about youth bipolar disorder. There's still a lot of doubt even within our field. So if you look at our adult bipolar disorder colleagues and even some youth psychiatrist colleagues, there's questions. Is there really a bipolar disorder diagnosis? And I'm not talking about, are the rates too high? People that are actually questioning that such a thing happens to a child or to an early adolescent, which is very surprising to me because we know that the typical age of onset, the most common is 18 to 20. So the idea of going 13, 14, to me doesn't stand out as unusual, but particularly when youth actually manifest the diagnostic symptoms. So I hope people haven't encountered this, but we do in the field. And I think part of the motivation for our work in terms of focusing on youth bipolar disorder and also in terms of demonstrating the biological and physical basis of it is driven by a desire to combat the stigma. So Emil Kraepelin was a really influential psychiatrist over a century ago. And I think one of the main benefits of his impact, or the main factors driving his impact, was he didn't have any theories. He just was a great observer of human behavior, of patterns, So really an epidemiologist. He didn't have moral approaches or religious approaches or psychodynamic or psychoanalytic approaches. He just looked at things and documented them really meticulously. And as a result, a lot of the observations that he wrote down have demonstrated to be true even now with the most contemporary research. And as he said here, in rare cases, the first beginnings can be traced back even before the 10th year. And the greatest frequency happens between the 15th and 20th year. That's over 100 years ago, and I would say that exact same thing is true today. No change to that. So I don't think it's true that it's a new invention. And so the question arises, what exactly is controversial? You heard from Emily, that brought it to life. You heard about the biological basis. I've told you that there's a lot of research on it. So what makes this so controversial? What I can tell you, although there's debates about where to cut diagnoses or what types of treatments, what's uncontroversial is that children and young adolescents can have cancer, can have stroke, epilepsy, multiple sclerosis, all of these very serious illnesses, several of them brain-based. And there's really no question that they exist, maybe questions about how common they are. What is controversial is this idea that a kid could, or a young adolescent could have bipolar disorder. You heard from Emily, 12 years old. That's pretty young, right? And so why is there this controversy? What is it about bipolar disorder? What is it about children that might explain why we have this double standard? What factors may perpetuate this controversy, belief systems that we have about the causes of mental illness, about the extent to which framing them as real conditions is truly believed? And I would say that when really pressed, a lot of people think it's real because it causes problems, but is it real? We think it's real. And what does it say about people's beliefs about bipolar disorder that it couldn't happen to a young person? So I don't have answers to these questions. It's just intended to be thought-provoking. Second statement, youth bipolar disorder is the same illness as adult bipolar disorder. I'll let you sit with that for a second. So to start off with, you heard, I think from Megan, talking about the different bipolar subtypes, and I just wanted to talk a little bit about that. How do we define mania? So an episode of mania is a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and persistently increased activity or energy. So that's the fundamental. You have to have that to have a manic episode. That's necessary, but it's not sufficient to have a manic episode. In addition to those things, you have to have at least 2 if your mood is elated, and at least 3 if your mood is irritable, of these other symptoms. Decreased need for sleep. So this isn't insomnia. It's being able to sleep 3-4 hours and then wake up and feel fine and refreshed and get through the whole day without falling asleep. Racing thoughts, stream of ideas. The spirit of mood disorder diagnoses in our current diagnostic frameworks, the one we use is the DSM-5, is that this is supposed to be abnormal for that person. You probably know people in your lives who are extremely gregarious, outgoing, don't need a lot of sleep, and that's their usual self. They can also have bipolar disorder, but they would need a change from that. So these are all things that are distinct change that are observable to other people, that cause changes in people's functioning. And the distinction between bipolar disorder type 1 and type 2 is based on the severity of these symptoms. So if an episode is so severe as to put someone in harm's way, require hospitalization, be associated with psychosis, as you heard from Emily, that's when we call it mania. And when the symptoms are somewhat milder, they can be just as long lasting, but they're not as severe, they're not as dangerous. We call that hypomania, so a more mild version of mania. And so bipolar 1 disorder has manic episodes plus minus depression, and bipolar disorder type 2 has what we call hypomanic episodes plus depression. There's also a third type of bipolar disorder we call not otherwise specified. The DSM term is cumbersome. It's other specified bipolar and related disorder. What that means is you definitely have these episodes, but they don't cooperate with the book. They don't last necessarily 4 straight days. Maybe you have them 2 days at a time. Maybe you've had 4 or 5 days, but you've never had a depression. So they're on the spectrum of bipolar disorder, but still with constraints diagnostically. When I got into this field, this was now almost 20 years ago. And at the time, there was very little data. But what we knew for sure was if you're an adult with bipolar disorder and someone asked you, when did it start? If you said that it started in your childhood or adolescence, virtually every aspect of illness severity was going to be worse. So early onset bipolar disorder, we'll define it somewhat arbitrarily as being in teenage years or earlier. affects 1/3 of the general population sample. So you heard from Alicia's presentation, some of her data was from a general population sample, which means they're not necessarily coming forward for treatment. We just found them in the community. So 1/3 have early onset in that setting. And if you look at CAMH or other clinical settings, it's fully 2/3. And those adults who will tell you that they had early onset of bipolar disorder have all of these other patterns, more associated illnesses, anxiety, substance use, hospitalization. They get ill more quickly after they get better. And the bottom line is they spend less of the overall time well. So at the time, that was the signal to us that early onset bipolar disorder was likely more complex than adult bipolar disorder. So this slide presents an apples to apples comparison. So in the blue column, what you see is youth with bipolar disorder type 1, followed prospectively over a period of up to 8 years. And using the exact same instrument, which measures week-to-week symptomatic severity for depression and for mania and hypomania, the same for adults with bipolar disorder type 1. And the universities that conducted these studies were also partially overlapping. So this is a really fair comparison. Youth bipolar 1 disorder versus adult bipolar 1 disorder. And you can see that for the most part, these are very similar in terms of most of the time is spent with depression rather than mania. And that people spend a lot of their time symptomatic, whether that's a full threshold episode. So, a full major depression lasts at least 2 weeks, virtually all of the time, significantly impairing. But depression, for anybody that's experienced it, we've all experienced sadness. That's not a comfortable experience. But a full day of depression, that's still, not a comfortable experience. So sub-threshold, as we call them, symptoms are really another source of symptomatic burden in bipolar disorder, and they're not trivial. The two differences between adults and youth is that youth straight up spend a greater amount of time symptomatic compared to adults. And the difference that you see here is amounts to about a month a year. So, maybe the columns, the difference in the height of the columns doesn't look that much to you, but I would say another month of the year with impairing symptoms, that's a big deal. The other difference that's more substantial is the construct of mixed symptoms that you heard about earlier as well, which is the intermixing of depression symptoms and manic symptoms. And this is observed in adults, but youth with bipolar disorder spend more time in those mixed states, which adds further complexity, I think, which explains in part some of the experiences our patients have in terms of delayed diagnoses. And Emily painted a very clear picture of that. So my final comment about youth bipolar being similar to adult bipolar disorder is based on a really recent study from our group. And advances in genetics have enabled us to move from going to one gene, and we learned very quickly that there's no one gene for bipolar disorder. There are certain one gene diseases like cystic fibrosis, but bipolar disorder, like cardiovascular disease, like diabetes, like hypertension, is what we call a polygenic, hundreds or thousands of genetic variants that collectively have an impact that confer risk for bipolar disorder. So that collective impact can be quantified into what we call a polygenic risk score. It's overall a summary of your genetic predisposition to a given illness. And what you see here are the polygenic risk scores for these psychiatric conditions. Bipolar disorder on the left, then schizophrenia, major depressive disorder, and ADHD. And this study looked at 3 groups of youth that were collected through our center over the course of over a decade. Those with bipolar disorder, depicted in orange. Those who had been referred for bipolar disorder, but we didn't confirm the diagnosis. They didn't strictly meet the criteria, but someone thought they had bipolar disorder. And then healthy control youth that don't have bipolar disorder or major depressive disorder. And as you can see here, there's generally an overall pattern where the genetic risk for all of these psychiatric disorders tends to be higher for youth with bipolar disorder. The only one where it was statistically significant was for bipolar. So what that means is youth with bipolar disorder, using genetic risk scores that were based on adults with bipolar disorder, have elevated genetic risk for bipolar disorder. Now, all of this may sound totally self-evident. Why wouldn't they? They have the same condition, you use the same symptoms. But again, like I said, this is something that people doubt. And we didn't, it's a plus and a minus. We would really like to generate genetic risk scores that are actually based on youth, not borrowed from adults, for reasons that are probably obvious. But the fact that these scores are based on adults and we applied them to kids and it showed the exact same pattern, explaining the same amount of variability, tells us that, yes, I can conclude this is the same condition as it is in adults. Next statement, bipolar disorder is overdiagnosed and overtreated in youth. So think about what your opinion is on that. So the first question is how common, if people think it's overdiagnosed, how common is bipolar disorder in youth? Dr. Anna Van Meter, who was with us earlier today, and her colleague, Dr. Eric Youngstrom, who was also with us earlier today, conducted what's called a meta-analysis. They scoured the entire world literature and looked at all of the studies that were community-based, not clinically based, so not hospital-based, but rather random samples of societies and a number of different countries, as you can see here, Canada, Brazil, US, Europe, etc. And those were a total of 19 studies reflecting over 50,000 youth. And what those studies found us in terms of key findings was that on average, if you look at the full bipolar spectrum, and I mentioned 3 types of bipolar disorder, but some of these studies had included somewhat looser definitions of bipolar disorder that didn't stick to the same rigor in terms of requirement of noticeability necessarily or duration. But overall, the full spectrum is up to 4%, and about 1 in 200 youth have bipolar disorder type 1. So that was on average. The second thing they found was that the prevalence has not changed over time. I showed you that information from Dr. Kraepelin from 100 years ago. And I mentioned that similar findings are observed today. As you can see here, based on at least the past 30 years, there is not a creeping up of the prevalence of bipolar disorder in youth. And finally, the more people kind of took shortcuts or held a lower bar for diagnosis, the higher the diagnosis rates, which I think is to be expected. And what we're generally trying to do when we diagnose bipolar disorder, you know, that group that came and someone thought they had bipolar disorder, you could say, well, why would you withhold the diagnosis? Our perspective is that there's different medications, there's different prognosis, there are different approaches that are required, and we really don't want to be flippant about the diagnosis, so we don't want to overdiagnose it. We also don't want to be so conservative as to say, well, you're going to have to wait until you're 22 and then you can come back and I'll diagnose you, because that's too conservative. So try to take a middle approach. And I think this tells us that if you take a broader approach, you may be more likely to overdiagnose bipolar disorder. How about Canadian data specifically? This is data that was published from Dr. Nicole Kozloff, who's also based at CAMH. She did this during her residency training. And if you just scan down the slide, there's a couple of great facts here. So first of all, unlike in childhood or adulthood, which have 1-to-1 ratios of female sex and male sex of bipolar disorder, it's significantly more common in teenage girls versus boys. And this is the general population. You see the same thing in clinical samples. Anxiety disorder rates on top of the bipolar disorder, almost half. Substance use disorders, as you heard from Alicia, a third. And suicidality, over 55%. So I would think this is the type of thing we see clinically. You wouldn't expect to see this in the community because people would not have as severe versions. But the question is, how can they have such severe manifestations? And part of the answer is what you see in the final line, which is that if you look at any form of mental health treatment, I'm not talking about lithium or DBT, any sort of mental health treatment, less than 50% had any sort of mental health treatment. And so to me, to some extent, there's no surprise that if someone has bipolar disorder and all these other conditions, that it would look as complex as it does if they're untreated. But to me, this also provides, and the study's a little bit dated at this point, but I think that largely the epidemiology is similar, where people tend to avoid until the very last second or until things are really, really dire. Oftentimes people come in because of suicidality or hospitalization. And so I do not think in any way that this is overdiagnosed or overtreated, as you can see from this data. That's Canadian data. And here we're looking at US data. So an even larger sample. It's the same study that Alicia was telling us about earlier. So there's a little bit going on here. So let's look at the blue columns. The blue columns, this study established a definition of what's considered severe. And that definition of severity was generally reflecting the extent to which something caused risk to someone or caused functional impairment to them. And so all mental disorders can cause severity, but in bipolar disorders, you can see 90% would have been considered severe, which means that unlike some other psychiatric conditions, it's rare that someone has a mild version of bipolar disorder. And then it becomes more common for things like ADHD or anxiety, but still, about half of them are severe. So I don't think we're so surprised that there's a variability in terms of the severity, but look at the discrepancy. So the red columns is the proportion of people with the diagnosis who receive diagnosis-specific treatment. So that means, like, if you have bipolar and anxiety, but you only got treatment for anxiety, you didn't really get your bipolar disorder addressed. And so Only 1 in 5 teenagers in the US population with bipolar disorder got treatment that integrated, that recognized their bipolar disorder. And that gap, that discrepancy between severity and treatment access is the greatest among all the psychiatric conditions. So again, in my view, further evidence supporting the conclusion that no, it's not overtreated. At a population-based level, it's grossly undertreated. That's not to say some people may have too many medications. You know, there's individual decisions that happen, or that someone didn't warrant a medication. But if you look at all of society, I think it's very clear that these are undertreated conditions. So you may be wondering, those kids that got referred to us that we didn't think had bipolar disorder, what was the reason we didn't think they had bipolar disorder? And I'll present to you a summary of those 139 youth that didn't have bipolar disorder. So the number one reason, over 50%, was that we couldn't confidently distinguish between their bipolar disorder and a co-occurring illness. If you look at generalized anxiety disorder, yes, it's focused on worry. That's the essence of anxiety. But other diagnostic criteria are restlessness, concentration difficulties, sleep disturbances, and so those are symptoms that we don't want to attribute to mania because they're overlapping. The mania has to prove itself to us that it's above and beyond their normal. So over 50%, we couldn't with enough certainty say that it was above and beyond. The second leading reason was that they never experienced at least 4 hours. So that's somewhat of an arbitrary cutoff, but it was one that was established by a prior landmark study in the US, and we adopted the exact same criteria so that we could compare our results to them. For the most part, these are youth that have, you know, the youth that we diagnose with bipolar have, like I said, 2 days or 3 days, but they don't have the full 4 days. But there has to be a minimum amount. You can't have bipolar disorder from an hour, no matter how bad that hour was. And so another quarter never had, you know, the better part of a day with hypomanic symptoms. For a quarter of them, it wasn't clear enough that they were recounting their own biographical memory when they were answering questions, or they weren't certain about things. And so there just wasn't enough clarity in the history or enough certainty. You know, it's a high challenge. We're asking people to reflect on their entire life. So they could come in at 18 and we're asking about symptoms that might have been described as happening when they're 12. But for a quarter of them, it wasn't clear enough to us in terms of the detail. Less common was that the manic symptoms that were described were just because of medication. So again, you heard about this from Emily, where sometimes people with a predisposition towards bipolar disorder or who already have bipolar disorder are prescribed a medicine. It could be often an antidepressant or a stimulant medicine for ADHD, or it could be corticosteroids that people take for really bad asthma. But there's a number of medicines that are known to precipitate the exact same symptoms as you see in mania, but they're generally attributed to the effects of those medications unless they continue on their own. And so about 1 in 10, they only had the manic symptoms as a direct function of a medicine they took. And about 1 in 10, we thought that they did have these episodes of hypomania, but they had less than 4 days in their whole life, which is the bottom, the minimum that we have for a diagnosis. And then the least common was manic symptoms that were solely in the context of substance use. So we do see people that have cannabis-induced psychotic symptoms or mania, but oftentimes those are precipitating factors, meaning that person had the predisposition, but that's why that episode happened when it happened, or it increases the number of those episodes. But most people that have manic episodes triggered by substances end up going on to have them on their own. So this is not one of the more common reasons. Just a very brief synopsis of what we know about treatment, and I'm not going to go into specific treatments. I'm happy to stay after if people have questions, but the plus signs are an index of how far along we are. So as you can see, when it comes to mania, acute mania, there's a lot of options. They're not perfect, but we have a lot of medicines that have been shown to be superior to placebo. That's clear. There's a few studies on depression. We don't have nearly enough placebo-controlled studies. So a lot of the studies are open treatment, which means someone comes in with depression, they get a medicine, they get better. Maybe it's related to the medicine. We hope it's related to the medicine, but we can't compare it to someone that didn't get the medicine. And so we can't with definitiveness say it. But there's a handful of those studies for ADHD, which is, we see it in about 40% of the youth that come in, a co-occurring ADHD. And there's been a couple of studies that have shown that if a youth has bipolar disorder and ADHD and their mood is stable, in these studies, people have tolerated the addition of a stimulant medication, like to use trade names, Ritalin or Concerta or Adderall, those sorts of things. So we know that it benefits the ADHD in these youth as it does in youth that don't have bipolar disorder. We know that in this relatively small studies that have happened, they haven't had adverse events, but you would need like much larger studies than we have to be certain about their safety. You heard from Alicia about substance use having very limited pharmacological studies and the maintenance phase of bipolar disorder. So this would be something, someone comes in with manic symptoms or depressive symptoms, they're treated to resolution. And now the challenge is, how long can you keep them stable and well? And there's really a gap in those types of studies. So we use medicines to help prevent or at least delay the onset of or diminish the intensity of recurrences of episodes. And the studies on that are really quite small so far. And I think a major gap that I hope will be addressed in the years ahead. And finally, anxiety, which is the #1 co-occurring condition that we see. I would say that for those of us in the clinic that see patients clinically on a day-to-day basis, it's the most common theme is anxiety. Mania, not that common. Depression is also very common, but really co-occurring anxiety is above 70% of the youth we see have at least one anxiety disorder on top of their bipolar disorder. And the standard of care for anxiety is cognitive behavioral therapy, also dialectical behavior therapy, or antidepressants. And those are, something to really think of carefully when you're dealing with bipolar disorder. And so far, there's almost nothing known about the treatment of anxiety. And so this is another gap. Lithium is something you may have heard of. So this is, I think, the original effective intervention for bipolar disorder. And it's as natural as it gets. It's literally a salt. You see a picture of it on this slide. And I would argue that it's not for everybody. It has downsides that are meaningful, and to use a dialectic, and it's probably the best treatment that we have at any point in the lifespan. Evidence in youth shows that in that longitudinal study where I showed you the bipolar 1 in adults versus the bipolar 1 in youth, those youth were followed for, as I said, 8 years. So the same study looked at medicines over that same interval of time. And they asked the question, during weeks that someone has lithium exposure versus not, is there differences in their mania or depression severity? And does it matter if that lithium was on top of another medicine or by itself? And what they found was that if you compare weeks of time where a person was on versus not on lithium, those people had half as many suicide attempts, lower depression severity, less aggression, and less functional impairment. And this study, although it's not a randomized trial, which means, as you've heard, like observational studies, we can't say cause and effect, but in a study of 446 youth, which is what this study is, followed over a very long time, controlling for a lot of things, it's about as close as we can get in terms of inferences. And then the other thing that was important to note is that these benefits were consistent. So they were consistent among youth that were younger than 18 or young adults who were older than 18. It was consistent, these findings that are in the above part of the slide, whether the lithium was by itself or on top of something else. And very importantly is that it was consistent whether it was bipolar disorder type 1 or spectrum of bipolar disorder as I've described us defining it. So as much as youth bipolar disorder is stigmatized, anything except for bipolar disorder type 1 is ultra stigmatized or I think often dismissed. And so sometimes people think that bipolar NOS is a trivial diagnosis. I won't get into the details today, but it's definitely not. And it also responds to the same types of treatment. So we have these belief systems and sometimes they don't survive data. The data really shows to the contrary. So my last statement of fact is, or fiction, is family factors have significant relevance for youth with bipolar disorder. So to start with, let's just talk about the course and outcome of youth bipolar disorder in general. So bipolar in adults in DSM is defined as a recurrent illnesses, meaning you have episodes, you get sick, you get better, you stay better, you have recurrences. And what we're trying to do is minimize the overall footprint of the episodes and symptoms of bipolar disorder in people's lives. So this is data from that 8-year study that I mentioned in youth. And what you can see, the different colors of those, what they're called survival analyses, time to new episode, and time to recovery of a given episode. You can see that across all the subtypes, the vast majority of youth with bipolar disorder experience recovery. We define that by 8 straight weeks at a minimum where there's no impairing symptoms in their life. So they have normal ups and downs, but they're not having disabling or impairing symptoms. So it's a pretty high bar, 2 straight months. And at least 80% of these youth got this initial study was a 4-year study. And obviously that number gets higher over time. So that's the good news. And then like adult bipolar disorder, as you heard from me earlier, it's the same illness. Over time, the majority will have some sort of recurrence, whether that's into depression or mania. That's as an overall group, but it turns out that there's different trajectories of bipolar disorder. And so to summarize from the longest analysis so far, which is the full 8-year study, what we know is that at the point of 8 years, about 50% are doing well the vast majority of the time. So at least 80% of the time, they're doing well from a mood perspective. Maybe people don't recognize that. I think it's a reason for hope. 25% are about half and half. So half of the time they're spending with clinically impairing symptoms and half of the time they're well. I would say, that's less good and a focus for improvement. And then of particular concern is the folks that are not doing well most of the time. So over 80% of the time, they're just ongoing symptomatic. The vast majority of these youth are not chronically manic, but they have symptoms that are getting in the way. They get in the way of their relationships. They get in the way of their family function. They get in the way of their career and academic aspirations. So this is really an imperative. So this study looked at those youth who had been chronically symptomatic. So you're talking by the 3-year mark, they had spent 80% or more of their time symptomatic. And what they found is over an additional years of follow-up, there was a separation in these groups. There was a type of this group that was chronically symptomatic, that continued chronically, and there was a subgroup that had substantial improvements and joined that mostly well group. And so the question is, what are the factors that may explain this? And as you can see here, in this graph, the group that improved was the group whose parental socioeconomic status improved. So if you had a parent, for example, that was unemployed and gained employment or had an improvement in the type of employment that they had, this was the key distinguishing factor of the differences in these trajectories. Socioeconomic status is part of the story, but so is parental psychological symptoms. So as you can see there in the middle, parental substance use disorder was a predictor of less likelihood of getting into that good, mostly well category. Parental bipolar disorder was also a predictor, although less strong than substance use disorder. And then there was an interaction of the socioeconomic status and the addiction. So for people whose parents had addiction, it was improvements in their socioeconomic status over time that mitigated this effect. So, the details of the statistics and the arrows, I think, are less important as the overall concept that you cannot take a youth with bipolar disorder, simply treat them as an isolated entity and expect everybody to get better. We know that it doesn't happen. And right now, we don't have systems in place that integrate the patient's family. I'm not saying the Center for Youth Bipolar Disorder is going to start treating parents, but I think that as an institution, our hope is that there's more of a lifespan perspective that would enable collaborations where parents who have unmanaged or poorly managed addictions or mood disorders, anxiety disorders, can have treatments that benefit them, because we have evidence from other conditions like major depression in mothers that if you treat major depression in mothers effectively, their kids' symptoms get better. It's not just a function of their self-report based on their mood. Their kids get objectively better, and there's a less likelihood of their kids developing psychiatric illnesses. So you heard about cardiovascular interventions, you heard about trying to avoid substance use, you heard about DBT, but another thing that we can do that is not currently part of our systems of care is optimize the family environment as it relates to mental health, not just to benefit that person who's probably in the workforce, a parent, but also to benefit their kids. So, how many ways could this benefit people to help them? And unfortunately, the reality in Ontario right now is that the average person with bipolar disorder hopefully has a family physician that will prescribe their medication. But a very, very small percentage see psychiatrists, and an even smaller percentage will see a psychiatrist repeatedly. And I think that we need to have a better system in place than that, because if you get hospitalized for a manic episode as an adult, typically you get about a month of aftercare in more intensive setting, and then it's back to the family doctor. And while I think family doctors are extremely capable, the barrier that places is if someone has a symptom exacerbation, there's so many barriers to seeing a psychiatrist again that by the time that's helpful to you, you've already gone to the emergency department. So we can't have a system that completely unplugs from the individual with bipolar disorder. Maybe it dials down the frequency of the sessions, but this is another area in terms of future directions where we have to do better. And then finally, from that bipolar spectrum condition not otherwise specified. If someone comes into clinic and they have had an episode of mania, with almost certainty, I'm going to advise them to take medicines to prevent mania. Generally speaking, even if they've only had one episode, we generally recommend a couple of years of maintenance treatment. And that's because mania for a lot of people can be a life-threatening illness. And so we really want to prevent it from happening. It's not something to underestimate, and it's not something to be delayed in reacting to. But it's a lot less clear for youth with bipolar not otherwise specified, where the symptoms are not inherently dangerous, and they cause more mild impairment. And so the question is, how much do you use therapy? How much do you use medications? The medications can be tough to choose from because, as you heard, anxiety is common, depression is common, and there's medicines that are less hard on the body, like regular antidepressants, fluoxetine or Prozac, for example, that are really effective for anxiety and depression, but we're extra cautious about them in bipolar disorder. So part of the question for the youth with the bipolar spectrum is, well, how likely are they going to go on to have the more clear bipolar 1 and bipolar 2? And as it turns out, the key predicting factor is whether they have a first or second degree relative with bipolar disorder. So as you can see here in the green line, if a youth has bipolar NOS or bipolar spectrum, and you follow them forward for a number of years, about 1 in 3 will develop the more clear bipolar 1 or bipolar 2. But if they have a family history of bipolar disorder, it's closer to 2/3. And that difference is really clinically meaningful, because if someone has 2/3 or 3/4 chance that this bipolar spectrum is most definitely going to become bipolar 1 or 2, that's a different scenario than having 1/3, I think, in terms of especially the medication decision. So here's an instance where just knowing a person's family history is of significant relevance to making decisions for that youth. So summary and conclusions. Youth bipolar disorder is the same illness as in adults. There are minor differences, as you heard about, primarily the mixed states and the percentage of time unwell. And it's associated with similar genetic factors. It affects almost 1 in 25 youth, so it is far from rare, but also not as common as anxiety or ADHD or things like that. Despite the perceptions of overdiagnosis and overtreatment among youth with bipolar disorder in the general population, the vast majority are undiagnosed and undertreated. There's been a lot of progress in the past 20 years. When I joined this field, I was drawn to it because I went to a conference and saw a book on pediatric bipolar disorder, had never even heard of that. So I picked up the book, and that was it for me. There was no data, there was so much controversy, so many people arguing, and it's just been a pleasure to see how the arguments have diminished as facts have built up. But despite those 20 years of progress, there's gaps that I've mentioned, and that's been my truth, is to say that, that there's significant gaps. Family considerations are relevant to diagnosis, to treatment, and to outcomes. And then finally, you've heard a lot about research, and I think progress has been made, but the pace is just too slow. So, we really have to have like a 10x, a significant increase in the amount of research that happens to get to the point that people are doing better more frequently sooner. Because I definitely, the idea of another 20 years is just unpalatable. So this is something that came up on my feed. This may seem random, but I'll walk you through it. The card that you're looking at is called the Koenigsegg Absolute. And what's interesting about the Koenigsegg Absolute, it was born in Ängelholm, Sweden, it is currently the world's fastest consumer car. And it doesn't have, I don't know if you've heard of Koenigsegg, I hadn't. I've heard of Ferrari or Porsche or these types of cars. And how did this company get to be in this point? It was just, founded less than 30 years ago. And so this was just a vision of an individual who created an ethos in the workspace of no compromises, no fear of failure. And if you read this article that came up, essentially the description was all about the fact that this was built on excellence of teams. So the car has a lot of carbon in it, which makes it really light. And there's like a whole team, and just the amount of passion and focus and attention to detail, the slope of the windshield, the tires, the engine timing, all these sorts of things. Each one had a dedicated team, and that was their whole thing. And they had a shared passion and a shared purpose, and it was in the goal of a fast car. So while our goal is not to create a faster car than this, the idea of these excellent teams resonates. And so that's where my dare comes in, is that the idea of The Center for Youth Bipolar Disorder is just one example. And the hope is that there be a series of these around the world. But at least at CYBD, I'm a single investigator, and now you've seen extremely talented, dedicated individuals that are very caring about this diagnosis. And so the hope is that in the years ahead, we will build these excellence teams. They're not focused on removing weight from the car. They're focused on the heart-brain connection. They're focused on depression and suicidality, whether it's the neurobiology that Dr. Dimmock from our group leads, or suicidality as a clinical entity that our DBT therapists lead, addictions that Alicia leads, and across all of these different teams of excellence, looking at causes, so fundamental research, prevention in terms of things that you would do to, keep people from having these problems, novel treatments, pushing the envelope on what we're willing to risk in terms of trying things that adults are trying, but that maybe aren't happening in youth, integrating patients and family, stigma reduction. I think it may not be tomorrow that all of these problems are solved. In the meantime, people have to know that they don't have shame from their illness, and their family doesn't have shame from their illness on top of the burden of the illness. So, stigma is really front and center of what we do, and it goes across all of these teams, and all of this in the service of hope. So I'll tell you a little bit about a project that hasn't launched yet in terms of receiving ethics approval or having all the details down. But what you see here is a team of folks. Some are in the audience. I want to acknowledge Gary, who is on the right in this photo and is present today. Thank you for joining us, Gary. And he gave me permission to share an anecdote. So Gary reached out to me by email, cold call. We never met before. He had heard about our work. He had been interested by our focus on youth bipolar disorder. And he said, I'm not a teenager anymore, but I have grandkids, and I'm interested in what is the implications for my grandkids. And I'm interested in them not going through similar courses to wellness that I've gone through. And so kudos to you, Gary, for reaching out. And this inspired some discussion internally about how this could be kind of a launching point to have CYBD partner with adult psychiatrists to focus on middle age, and adult psychiatrists to focus on late life, which has all of its own challenges and complexities. So you see in this picture, the chair of our department, Dr. Benoit Molsant, who happens to be a geriatric psychiatrist focused on bipolar disorder, Joyce from our team, other colleagues on our team. And our hope is that we will create, similar to the study that led to a lot of the research that I showed you, a large sample of families affected by bipolar disorder. So hopefully by next year, we'll be well into recruitment. But the idea is, if you have bipolar disorder and you're from 13 until end of late life, 90, whatever, if you're willing to bring a relative or more with you to the study, that's the inclusion criterion. And we would look at patterns of how the disease manifests across different generations, genetic factors, similarities and differences. And once that large sample is collected, it would serve as a platform from which to launch treatment trials, causal mechanistic trials with brain imaging and heart imaging and that sort of thing. So right now, this is a dare in the sense that we don't have the study up and running, but it's also a challenge to our own team to get it up and running so that next year we can tell you about how it's going. So our hope is to use research to begin moving to that place that I mentioned, where families are integrated and the whole unit is considered, and even if they don't live together. So with that, I wanted to acknowledge our funders, and in particular, our patients and families who give us a tremendous amount of trust. They answer a lot of questions. They provide us with a lot of different biospecimens. They lie in MRI scanners. The scan that Megan presented to you of heart imaging, they do their brain imaging and heart imaging at the same time. They lie there for an hour and a half. And why do they do that? Because they trust us, because this isn't trivial, because we're looking to do something for them. And so I really want to acknowledge their courage and their generosity of spirit for participating in these studies, for creating the booklet, for Reasons for Hope, for Youth, by Youth, which you can pick up on your way out. And finally, just to thank the team at the Center for Youth Bipolar Disorder, who I can attest to on a day-to-day basis brings full attention to detail, full caring, provides full dignity and respect and compassion for the youth that we see. And it's really an honor to watch them develop and grow. So with that, I'll thank you for your attention. Invite the folks that spoke to come up and take any questions you may have in the audience or folks online. So thank you also for joining us. So, all right, well, we'll start, maybe we have a online one first. Let's see here. So the first, I think Emily has stepped out, but for folks who are willing to stay, we're going to answer all the questions that you have. So this was a comment to Emily. What a tremendous presentation from such a brave young adult. Please let her know that it's an inspiring to hear her story, and we're going to do that. Let's see here. That's all we have. So one of the questions here is, why is there a long, thank you. Why is there a long wait to see a psychiatrist? And why do patients only get 1 or 2 sessions instead of being followed for longer periods? So thanks for that question. I don't know if it came before or after I made my comment. I think it's a totally fair question. The direct answer is a resource to need mismatch. So the number of people that need to be seen by psychiatrists greatly exceeds the number of psychiatrists we have. And so our system just is not built to be able to provide what I would consider the ideal or the gold standard treatment. It's not an explanation per se. I think it's just a reality that people have to decide what they're going to do. Are they going to see, 40 patients monthly, or are they going to be able to be accessible to people when they get sick? I'm not saying we have it down right in Ontario. We don't really have much of a system in our healthcare system. So just to validate that this bothers me too, it bothers us too. So another question is, how do you prioritize referrals in this context? Especially when someone shows early warning signs, but no outright severity. So generally speaking, in society at large in Ontario, things are expedited when there's risk to people or others. So that's an unfortunate fact because it means that things have to wait to that point. What I can answer and what I'd rather answer for is the Center for Youth Bipolar Disorder. So we take a certain approach, and I'm not saying it's the right approach. It's the approach that we've given thought to, and that approach is that we focus on youth bipolar disorder. And there's many youth that have emotional dysregulation and mood problems, and they have great challenges as well. But in my perspective on this is that we really want to be accountable to our stakeholders, meaning that if we have a promise, we can deliver on it. And if we promised all mood disorders, we wouldn't be able to deliver. But we can, for teenagers with bipolar disorder or with clear reason to suspect bipolar disorder, often offer accessibility. So we see people, last year's presenter was from Timmins, Ontario. So we see people from across Ontario, and the signs that they have to have would be either any sort of psychiatric problems with a parental diagnosis of bipolar disorder, or early signs of discrete episodes like what you heard about with differences from normal in their manic symptoms. Could you explain the underdiagnosis, especially in the absence of family history? Why is it underdiagnosed? Maybe I'll ask, do you guys want to share your thoughts, or Andrew, do you have a thought about why it's underdiagnosed?
I think oftentimes there's so much kind of stigma out there that people don't actually talk about it that much. And one thing that we've actually noticed is there's such in Ontario, there is such a short list with getting a family doctor and be able to even be able to access a psychiatrist. It's kind of challenging. So it's quite a burden from the community perspective to even support a lot of our clients because they aren't able to access appropriate healthcare. So oftentimes they'll be coming to community settings because there's a bit of a wait list, but that's the best that we can sort of support them until they're able to access different types of specialists in healthcare.
Thanks, Andrew. And just another plug for MDAO, which is that one of the best things about the partnership that we've had is that we have strengths and MDAO has strengths, and they're complementary, and we both kind of acknowledge each other's areas of expertise, and it's been great. We know when there's families that are struggling, or maybe their youth doesn't want them involved as much as they'd like to be. We've heard back a lot of really positive things about the supports you guys have given. So thanks for, it's not the healthcare system, but it's definitely providing important patches. This one is for Dr. Sultan. So how does the youth with using cannabis with bipolar disorder compare pre versus post legalization?
Good question. So yeah, so we do know after legalization, there's been a decrease in the perceptions of harms and an increase in cannabis availability. So in terms of literature, it is mixed out there, whether there's increased use specifically in the youth with bipolar disorder, but or just specifically in general, we don't know whether youth are using more or less. We know that in older populations, they're definitely using more. When it comes to clinical implications, due to there being increased availability, we do assume that there would be increased use and then which would lead to more deleterious clinical implications.
So another follow-up to this, and I think this is a fair point, which is for a 14-year-old, it's still not legal. Do they still have a barrier to use, or is there not really a barrier at all? Or
yeah, so they have a barrier in terms of they can't buy it in stores like people who are 19 years and older are, but because there's so much more accessibility to this, that it's probably much easier for them to get cannabis after legalization, with so many cannabis stores being around than there was pre-legalization.
thanks, Alicia. So we'll turn to the audience. Is there anyone that wants to pose a question just on the top of their mind? We've gone through all the cue cards, and we have a question from the audience in the online chat. So one of the questions is, what are the similarities of this condition with schizoaffective disorder? So for those who are not familiar with the term schizoaffective disorder, when someone has clear-cut primary psychosis, which means it's the main thing that they have, and it's chronic, we call that schizophrenia. And then there's bipolar disorder, where people can have psychotic symptoms, but it's either exclusively or almost exclusively in the context of depression or mania. And when people have clear-cut episodes of bipolar disorder, but they also have psychosis by itself, not with depression or mania, we call that schizoaffective disorder. And I would say that for the most part, the management is largely similar, with the exception that you're probably more likely to use an ongoing antipsychotic medication. So another comment is, I'm not sure if people think about the management of bipolar disorder using mobile apps, even biometrics apps like a heart rate measure. You want to say something about that?
So at the research symposium earlier, we actually had a really interesting talk from Anna Van Meter in New York. And she's looking at smartphone data in youth with bipolar disorder, both to determine kind of its utility as a diagnostic tool. So whether looking at smartphone data prior to diagnosis can help inform whether someone ends up getting a diagnosis of bipolar disorder or a different condition. And then also using that data to predict mood episodes or risk for mania and depression moving forwards. So in her studies, in terms of smartphone data, they're looking at like sleep-wake time. So how often teenagers are on their phones at night. And you could see in youth with bipolar disorder, they're spending, significantly less time sleeping, more time on their phones. Some of those measures kind of mapped on to kind of risk for mood episodes. And then in terms of the biometrics apps or heart rate measures, there are wearable devices that are being used kind of, at least from a research standpoint, looking at heart rate variability and step count. And I think that those things are definitely at least useful from a research perspective. I know that there are a lot of kind of mood tracking apps that are just accessible through the App Store. And I think even those are beneficial, just being aware of where your mood is at, noticing certain triggers and kind of incorporating that into day-to-day life, I think is just beneficial broadly. So yeah, I think there's still a lot of work to do in terms of like wearable devices, but it is an area of research that I think more attention is being placed on.
Thanks for that answer. So this is a very balanced Q&A. This one's for Vanessa. Have there been any studies on the efficacy of DBT when trained in person versus virtually? From personal experience, I've benefited from face-to-face interaction, so I'm wondering if youth in the study feel the same way.
Great question. I can't speak to if there's been any research studies, virtual versus in person, so I'm not sure about that part. I can speak like from personal experience and from what I've heard from patients that I've worked with. I think there are certainly benefits to attending in person. You can build a connection perhaps a little bit faster than virtually. And that being said, I think I've absolutely built a really nice connection with all the clients that I've worked with virtually. Certainly, I think we're able to access more clients than we would be able to if we were only meeting in person. So as Ben mentioned, a speaker from last year lives in Timmins, Ontario. And so it's been wonderful to be able to reach people who don't live immediately in the GTA, and who they're also able to hop on right after school, for example, and not have to commute in. So I think there's pros and cons to both virtual and in person.
Thanks, Vanessa. So there's just, is Golda still here? Golda here?
She's in the room.
Okay.
Yeah.
Do you mind grabbing her? And we just want to acknowledge the Golda. I'll just tell you about her is that she led our research day today in terms of organization, and I just wanted to have her come up and receive a card. But also just finally ask it any other questions that folks have top of mind. Yeah. Yeah. Okay. Yeah. Yeah. So very fair question, and I don't think there's an easy answer to it. The question was, what can you do if someone's entering crisis mode or in crisis mode to get them access to treatment? What I would say is that people's beliefs about the right to access treatment is shared by their providers, and it may sometimes seem like because those providers aren't accessible, they have a different opinion, but it's not the case. I think there's a lot of kind of hand-wringing and consternation about the fact that for every patient people see, they know that there's a lot more. What can a loved one do for someone else? I think being honest about what they're seeing. So a lot of the time we see people that had delayed access because they didn't agree that they had symptoms or they didn't want to go. And so providing the support to that person, non-judgmental, repeated encouragement, and try to, give them the social structure they need to help get to treatment. But in terms of the basis of your question, how do you get them a psychiatrist faster? I don't have a solution right now, other than earlier the better to make a referral, because that time is just gonna go. Golda, come on over. So join me in thanking Golda for helping organize today. And thank you so much for staying this whole time, and your presence here means so much to us and gives us our purpose and our drive. I hope you come back next year. Let us know if there's other topics you want covered, ideas for research, and have a good night.